We're going to focus on chapter 31, ear and hearing disorders. Again, I want you to pay close attention to things that have been starred, asterisks, emphasized, etc. as we move through. Some of the topics are going to be your anatomy and physiology overview, which you need to review page 485. We're not going to go into heavy detail on that. Ear assessment is another very important thing. You need to be able to obtain a history and examine the ear. Hearing screenings is important. Cerumen removal and the 3 types of hearing loss. Then we're going to move into more of the disorders. Foreign body, otitis externa, otitis media with effusion, perforated TM, a cholesteatoma, mastoiditis, etc. Again, on page 45, 46, you'll see an A&P overview and ear assessment. Very important. You need to be able to take a good history, especially with kids. A very detailed history is important. Do they stick things in their ear? Do they have a hearing problem already? Were they premature? Does the family have hearing loss as or deafness as family history? Physical exam can be very difficult. One thing I do recommend is that you look in every ear, every eye on every patient until you get comfortable looking in ears. I think pediatric ear exam is the hardest thing to be able to differentiate normal and abnormal. So in clinic, every ear you can look in, okay? Kids, adults, everybody. In children, you want to pull down, out, and back when looking in their ears so that you've opened that canal enough to get the speculum in. And again, you need to use the proper tools. You do not want to use an otoscope speculum that's way too big. You're going to hurt the person. Kids, there are very small ones that you need to use. Okay, and look at the ear before you start sticking things in there. You need to assess the external ear first. Make sure you don't see anything in there that you're not going to shove into their tympanic membrane. Okay, you want to do the ear exam at the very end of the exam. You don't want to start with that because you're usually going to cause them to squirm, maybe cry, and then the rest of your nose and throat exam, listening to their heart and lungs, is going to be more difficult. Okay, you want them to be seated on the parent's lap if they aren't able to sit on the table. Biggest thing is what is important to that. The biggest importance is what is abnormal. Okay, if you look on page 486, it goes into the red flags for hearing loss. Very important. Again, those milestones, the developmental milestones, if they're not hitting those, it may be normal. It may say that they're just behind, or it could be a sign that something is grossly abnormal. So if you have an infant, a newborn that doesn't startle to loud noises, if they don't turn their head towards a noise at 6 months or older, if by a year old they're not at least saying mama and dada, very small single words, etc. When you move into early and middle childhood, if they have delayed speech, can be a sign of hearing loss. Difficulty following instructions because they can't hear you. It's not that they're ignoring you, they can't hear you well enough. Teachers concerned about paying attention. You may get a note from the teacher that says, oh, I can't keep his attention, he doesn't follow directions, etc., etc. Often saying huh or what, turning the volume up or on their TV, their radio, tablet, whatever. If they're having to listen to it at very high levels, you may need to have them checked out. Also, table 31.1 goes over the normal developmental milestones for hearing impaired children. That's important for you to look at, mainly to be able to know what's normal and what's abnormal. Okay. And it tells you at what age each of these things. So that is something that could be questioned on exam. So make sure you review table 31.1 on page 486. So hearing screen in pediatric patients, it's usually completed in the hospital right after they're born. And then after that, the American Academy of Pediatrics Early Hearing Detection and Intervention recommend a 136 guideline, which includes hearing screening completed by 1 month of age, diagnosis of any hearing loss by 3 months of age, hearing aid selection and fitting within 1 month of confirmation of hearing loss, and entry into an early intervention service by 6 months of age. And all of this is to promote early intervention, because you should know, if you don't already, I'll inform you, hearing loss is going to also lead to speaking deficiencies and can have other, the patient can have other developmental milestone abnormalities. Okay. Another good source for screening of hearing is the American Academy of Pediatrics Bright Futures. I've actually linked the PDF version of the Bright Futures in our Moodle course under additional resources. You need to be looking over the Bright Futures. It gives you a lot of information regarding different milestone, developmental milestones, screenings, etc. But Bright Futures recommends pure tone audiometry at 4, 5, 6, 8, 10, 13, 16, and 20 years of age. Okay. But if somebody is in between those or younger than that, you still, it depends on the patient when you do those assessments. If you're seeing someone that's high risk for hearing loss, craniofacial anomalies, persistent or recurrent otitis media, middle ear effusion, and chronic exposure to loud noise, you're going to assess them more frequently. Okay. Those same things also, you need to assess their speech more frequently. Okay. Always remember, hearing and speech go together. If you can't hear, you can't speak very well, because you don't hear yourself saying the words, and you don't hear other people telling you how the words are said. There are a lot of different diagnostic tests, studies that are done to screen for hearing loss. Your book goes into those starting on page 487. You can have the evoked autoacoustic emission, universally used as a screening tool. Auditory brainstem response and pure tone audiometry, that's usually done by an audiologist or ENT. Conditioned play audiometry is another one. Pneumatic otoscopy assesses TM mobility. That's important to know, because that's something that you should be able to do. There is a little attachment, a bulb attachment for your otoscope that you blow air into the ear, and it should rebound off that tympanic membrane. If there's no mobility of the tympanic membrane, further testing needs to be done. Okay. Tympanometry, ENT audiology is going to do. Screening audiometry starts at about 4 years of age, and that's where they put headphones on and they have to raise their hand when they hear the sound on each side. Okay, and this detects unilateral and mild hearing loss. Altered mobility of the tympanic membrane can be caused by middle ear effusion. Okay, so if you don't know how to assess the tympanic membrane for mobility, you need to learn. Again, look in every ear that you can look in. Hearing impairment. There are 3 main types: sensorineural, conductive, and mixed. Sensorineural is most commonly associated with dysfunction or damage to the inner ear or auditory nerve. It's almost always permanent. Conductive, it could be congenital or acquired, and it's a problem in the outer or middle ear. And then mixed is a combination of both. I'm not going to test you on all the specifics. You need to just know the difference between the 3 types and how are you going to treat that. Okay, and there are different ways for treating. Of course, one of the most important things is if they have acute otitis media or otitis media with effusion, that needs to be treated. Okay, screen for hearing loss if they have bilateral middle ear effusion for more than 3 months. and they need to be seen by ENT. Okay, if the child fails a screening, they need to be referred to an audiologist. Genetic counseling if there's some kind of hereditable cause or genetic predisposition or is suspected. Encourage the use of amplification devices early as appropriate to improve school readiness and engagement, cochlear implants or hearing aids, and we move into other types of treatment that you're likely not going to do. But you can do the referral for genetic counseling. You know, if you get a note from a school or a parent that says they failed their hearing screening, you're going to refer them, okay? So next we're going to move over to foreign bodies in the ear. One thing I'm going to say is do not remove anything that you are not comfortable removing, okay? Symptoms, the child's going to admit that they put something in their ear. Parent sees them putting something in their ear. They're going to have a buzzing sensation. If you're feeling a fullness in their ear, persistent cough or hiccups, and usually they have pain and otorrhea, okay? Management, you want to try to pull it out if you can, okay? If you can't, leave it in there and send them to ENT or to the emergency room, depending on what you think it is, okay? If it's soft, irregularly shaped objects, you can use forceps or a curved hook. If it's an insect or a bug, you want to kill it with mineral oil or lidocaine first and then try to pull it out. The biggest thing is to know what not to do. You do not irrigate or put anything in the child's ear if you do not know if the tympanic membrane is intact or you can't see the tympanic membrane, okay? That needs to be sent, okay? If it's a disc battery, do not irrigate. You're going to break down that battery and cause more damage than the battery is causing. If it's organic material, you don't want to irrigate because you can melt it and push it further into the ear, okay? Again, refer if you can't easily remove it. If the child's uncooperative and you're scared that you're going to hurt them or cause irreversible damage because the child is fighting you. If they're in severe pain, if the object is on the tympanic membrane, or if it's been there for more than 24 hours, you probably need to refer. And that's the most important thing to take away is what do you not do? Again, tympanic membrane is not intact or you can't see it. There's a disc battery, organic material. Refer if you cannot see it and remove it easily. If the child is fighting you, if they're having severe pain, or the object is on the tympanic membrane and or has been there for more than 24 hours, okay? Antibiotic or steroid drops may be recommended post-removal depending on how long it's been there and what it is, okay?
There are two ear disorders that you are going to see at some point, even in teenagers, adults, but especially common in children, and that's otitis externa and otitis media. Those are two disorders that you need to know how to treat, okay? Otitis externa is swimmer's ear, if you don't already know that, and this is inflammation of the external auditory canal. They can have a simple infection with edema, discharge, erythema. They could have furuncles or small abscesses, or infection of the superficial layers of the epidermis. The most common pathogen is Staph or Pseudomonas. Symptoms: itching, irritation, pain, pressure or fullness in the ear if the child's old enough to complain, otorrhea, external auditory canal or periauricular edema. You may see that it looks a little swollen in there, and they can have pre or post-auricular lymphadenopathy. They're probably going to be pulling at their ears, and when you go to touch them to examine, it's going to hurt, okay? This is the one where you push on the ear, on the pinna or tragus, and it hurts, okay? That's the first thing you're going to do if you suspect otitis externa. It may be very painful for them to have an internal ear canal exam with the otoscope because of how swollen it is. Sometimes you may not even be able to get in to look at the tympanic membrane. You may have to treat it, let the swelling go down, and then try to do an exam after. During exam, of course, you're going to have pain with movement of the tragus or pinna. They're going to have a swollen external canal. They can have regional lymphadenopathy, tracheal tenderness. You can even see red, crusty, or pustular spreading lesions. And if they do have any type of drainage, it's going to be thick otorrhea. Treatment, eardrops are a mainstay. You want to use acetic acid or antibiotic with or without steroids is usually the treatment of choice. Neomycin drops should not be used if you cannot visualize the tympanic membrane, because if there is a tear in the tympanic membrane, this can cause damage to the cochlea. We don't want to cause hearing loss trying to treat otitis externa. Quinolones are good for Pseudomonas, staph, and strep if otitis externa is a complication of otitis media. You're not going to use systemic antibiotics unless the infection has spread. If they have severe otitis externa and they're having a lot of symptoms, a lot of problems, you may want to use systemic antibiotics, but this is on the outside of the ear canal. So think about how antibiotics work. It's probably not going to do a whole lot for something that it's not getting close to. And of course, you want to use analgesics for pain, Tylenol. If it's an older child, a leave ibuprofen. Prevention, of course, they need eardrops prior to and after swimming. You can use a low setting on a blow dryer to dry the external ear canal. They have special earplugs that you can put in when they go swimming, when they are in the bathtub, in the shower, etc. Look over the table on page 655 about management also to kind of refresh your memory.
So next is otitis externa. This is swimmer's ear, is what it's most commonly known as, and it's an inflammatory reaction resulting from irritation or maceration in the external auditory canal. Usually happens after they have been in dirty water, most often. What are the most common pathogens in otitis externa? Most commonly is Pseudomonas and staph, but you could also have strep, Aspergillus, Candida. You could have a mixed where it's got multiple bacteria in there. But it's important to know that the most common is going to be your Pseudomonas and staph. What will the patients present with? Again, page 493, your book goes into clinical findings, physical exam findings, etc. But they're usually going to have itching, irritation, pain. The book points out that the pain is usually disproportionate to what is seen on examination. So it hurts them a lot more than how red and irritated it is on the outside. They can have a feeling of pressure or fullness in the ear. They could have some hearing loss, drainage from the ear, edema in the preauricular or postauricular areas. They can have some lymphadenopathy, some cellulitis can be present. You're going to, on physical exam, you're going to see that it hurts when you touch the tragus or pull the pinna. When you try to look in the inner ear, it hurts them. They're going to pull away. You may see that it's swollen red in there. You may feel the lymphadenopathy. They may also have lesions, pustules, etc. in there. Pruritus is common. They could have a dry. The most important things you're going to be looking for is when you push on that tragus, it hurts. When you try to examine, it hurts, and it's usually red and irritated on the inside. Okay. Management, page 494, they go into, page 493, I'm sorry. They go into detail. Eardrops are the mainstay. Symptoms should improve within 7 days. Resolution may take up to 2 weeks, though. Okay. Page 494, table 31.4 gives you all the normal, commonly used topical preparations. A couple notes for that. You need to know if the tympanic membrane is ruptured before you put anything in someone's ear, okay? So if you're using something with neomycin, If you can't see the tympanic membrane, or you don't know if it's intact, or if you see that it's not intact, you do not use neomycin. Okay, you're going to usually use something that has acetic acid or antibiotic with corticosteroid for otitis externa, but no neomycin if the tympanic membrane is not intact or you can't see it. Okay, usually you're going to use a quinolone to treat otitis externa. If it's a complication from acute otitis media, you can use systemic antibiotics only if there's extension of infection beyond the ear or there's other problems going on. You want to educate the parents to administer the drops with the child laying down with the affected ear upward, and put enough drops to fill the canal. Okay, that's important. If the infection is not improving within the first 2 to 3 days, you may need to look at the ear again and come up with a new diagnosis or refer, depending. Okay, they don't need to manipulate the ear. They don't need to get any more water in their ear, etc. Big thing that you need to know is with swimming. Okay, they can use the ear drops that dry the ear after swimming. You can use a blow dryer on the very lowest setting to dry the ear, but really you don't want, especially dirty water, sitting in the ears. Okay. Earplugs during water sports, they do not recommend using earplugs in clean water anymore. Use swimming pools, bathtubs, etc. If you're going to be in a lake, river, something like that, you probably want to tell them to use earplugs. And again, on table 31.4, it goes into the different topical preparations, and there you will see that there are some that are contraindicated with a tympanic membrane perforation or the integrity is unknown, and that's usually your cortisporin and Cipro, as well as neomycin, like I said earlier. Very important to know. The rest you can use with a ruptured TM, but no cortisporin or Cipro. At this point, you should be familiar with acute otitis media. Very common, especially in children. Very, very common, and it's just an acute infection of the middle ear. You need to be able to properly diagnose it to reduce overtreatment and antibiotic resistance. Okay. To diagnose acute otitis media, you need to have the following: recent abrupt onset of middle ear inflammation and effusion, which includes ear pain, irritability, otorrhea, and/or fever. One of the first signs, especially in babies and small children, is they'll start pulling at that ear. Okay. Moderate to severe bulging tympanic membrane, limited or absent mobility on pneumatic otoscopy. There's an air fluid level behind the TM that you see on otoscopy, and or otorrhea. They have signs and symptoms of middle ear inflammation confirmed by distinct erythema of the TM or ear pain. Again, they're going to pull, tug, constantly be touching their ear because it hurts. Okay. There's multiple different types of acute otitis media. The most common pathogen is going to be the strep pneumonia. Risk factors are recent upper respiratory infection. Babies that are not breastfed are more at risk than babies that are breastfed. Smoke exposure, secondhand smoke, people smoke in the house or the car, daycare because they're exposed to everything, and then prematurity is also a risk factor. If you look on page 495, box 31.3, it goes more into detail, but the biggest ones are prematurity, daycare, tobacco, smoke exposure, not breastfeeding, and recent upper respiratory infection. Okay. It's common to have acute otitis media as a secondary bacterial infection to primary viral infections such as RSV or the flu. Okay, that's very important to know. Acute otitis media, and we'll talk about that again when we get to the RSV and flu lecture, but it is common to have otitis media after RSV or flu. The book goes into pretty good detail about acute otitis media, and we'll kind of move through that in the upcoming slides. All right, so next we're going to move into treatment. It's very important for you to be able to properly diagnose acute otitis media in order to treat it. You're going to start with watchful waiting, treat their fever, treat their pain, Tylenol, Motrin, etc. You always want to base your treatment on child's age and the severity of their illness, okay? You're not going to treat every patient the same way. That's for kids and adults. Antibiotics are usually effective. You're going to start with amoxicillin, and if you look on page 497, you'll see medication commonly used to treat otitis media. Table 31.6 gives you the treatment guidelines. Those are both important to know, but you're going to start with amoxicillin. That's first line, always. You're going to try to avoid azithromycin because of the high incidence of bacterial resistance, okay? If there's a penicillin allergy, you have a couple different options. You can use the Cefdinir. You could use cefpodoxime. You could use Rocephin. Rocephin is very costly, so you may not want to do that. It's IM also. Do you want to give the person a shot? If you're in a clinic and you have it on hand, you may want to just go ahead and do that. Treat it now. Let's see. The table goes into a lot of detail, but really I just want you to know your first line treatment, amoxicillin, and what can you use if they have a penicillin allergy, which is your Cefdinir and cefpodoxime, or if you want to give them an injection, the ceftriaxone, okay? You may see a difference between textbook treatment and real world treatment when you're in clinic. That's perfectly normal, but you need to know what the current clinical guidelines are, because that's what is going to be on boards. It's not going to be, your preceptor treats it this way. Your preceptor automatically gives a Z-Pak, or your preceptor automatically gives a Rocephin shot. If that's not the current clinical guidelines, that's not what the answer is going to be on boards. Okay, so keep that in mind. And it does go into a lot of detail on page 496 under management. Again, watchful waiting is usually what you want to start with for the first 2 to 3 days. And then you're going to go from there. Of course, if they have persistent, if you give them an antibiotic and it's still not going away, you probably need to use a broader spectrum, a stronger antibiotic. You may also need to refer them to ENT. The biggest things to refer is if they have chronic otitis media with effusion that has lasted longer than 3 months. If they have 3 episodes in 6 months or 4 in 12 months. If the child has craniofacial anomalies, or they're at risk of chronic otitis media with effusion, or if they have chronic otitis media, you can't get fluid to drain behind their ears, etc., and you think they need PE tubes, send them to ENT. Complications associated with untreated acute otitis media include mastoiditis, hearing loss, facial nerve paralysis, cholesteatoma formation, and labyrinthitis. Okay, we don't want to cause hearing loss because we're not treating otitis media the way we should be. Okay, we also want to try to avoid antibiotic resistance. That's why we're going to start the watchful waiting first. And again, I discussed this in the conjunctivitis section, but if they have conjunctivitis and concurrent otitis media, treat both. Move into otitis media with effusion. This is basically a middle ear effusion where there's fluid behind the tympanic membrane. You're going to have patients complain of If they're old enough to understand what hearing loss is, they may tell you they can't hear very well. Or if you have a younger child, the parent may notice that they have to turn up the volume on the TV or tablet or whatever it is because they're not able to hear as well. The child may also have complaints of ear pain that comes and goes. It's not all the time, or they feel like their ear is full. Things like that. When you look inside the ear and you do the pneumatic otoscopy, you're going to see decreased tympanic membrane. The TM may look dull. You may see an air fluid line. It may be opaque. You may not be able to see any of the physical landmarks within the ear. Risk factors associated with risk factors for hearing loss associated with otitis media with effusion include recurrent or chronic otitis media with effusion, speech development that is slower than their peers, speech is less clear than before they had the otitis media with effusion, etc. Management, watchful waiting is the number one line of treatment, I guess you could say. You're going to just watch and see if it resolves on its own. It usually does within the first 3 months. If it doesn't resolve after 3 months, you need to do hearing tests, screenings to make sure they haven't lost any of their hearing. Intranasal steroids, systemic steroids, antibiotics, antihistamines, etc. They're not recommended and probably not going to help. I have seen ENT give systemic steroids to see if they can get it to drain, decrease the inflammation, but it's not always very successful. If they're at risk for speech language developmental delays, they need to be referred for speech therapy, audiology to treat the hearing loss, etc. You want to reevaluate every 3 months until it resolves, or every 3 to 6 months for children with chronic otitis media with effusion. A lot of education is required for parents, caregivers. You want to refer to ENT if there is impending structural damage of the tympanic membrane, if there's significant hearing loss, or chronic or persistent effusion that lasts more than 6 months. That's important to know who to refer to ENT. If the child is younger than 4 years of age, PE tubes are placed for chronic otitis media with effusion. They may also do, tubes and adenoids is what is usually referred to, and they remove the adenoids and the put in tubes at the same time. The main complications from otitis media with effusion are recurrent acute otitis medias, hearing loss, which can be permanent. So this is why you want to make sure it does resolve before it causes chronic or persistent permanent hearing loss. So perforated tympanic membrane, it can be spontaneous, it could be related to trauma. You need to be able to look in and see that the tympanic membrane doesn't look normal. You may see the actual hole. If a patient had tubes put in and the tubes have fallen out, you're going to see a hole and maybe some scar tissue around where the tube was. Most common causes are acute otitis media and otitis media with effusion. They may have some drainage from the ear. They may have initial pain that then goes away, no symptoms at all, etc. Sometimes they'll have like a whistling sound when they sneeze, cough, etc., blow their nose. Treatment, if it automatically makes them more susceptible to infection if water enters the ear canal. So they need earplugs or something to block the ear from getting water in it. They need to keep the ear dry, even during showers and things. You don't want water to sit in the inner ear. Every now and then they may need treatment where they put a patch over it, but that's very rare. Really, it usually heals on its own. Again, you need to go back to where we talked about what drops can and can't be used with a perforated tympanic membrane, or just pressure equalizing tubes that they put in to help relieve fluid behind the tympanic membrane. They no longer advise protecting the ears from clean water. Again, I talked about this earlier. Pool water, the chlorine gets rid of most of the bacteria in there, or if it's, in the tub or shower. If you're going to be ponds, lakes, rivers, etc., they do need earplugs. If they have foul discharge or an odor coming, that usually indicates that they have an infection with the tube in place, so they need to be seen by an ENT.